Welcome to this video entitled Diabetes Mellitus. As a way of introduction, diabetes comprises a group of metabolic disorders characterized by chronic hyperglycemia, with disturbance of fat, carbohydrate and protein metabolism. This results from defects in insulin secretion, insulin action or both. Approximately 2.9 million people have been diagnosed with diabetes in the UK. By 2025, it is estimated that over 4 million people in the UK will have diabetes. This can be accessed at www.diabetes.org.uk. Within the UK hospital setting, approximately 16% of inpatients have diabetes. These patients tend to be elderly with multiple comorbidities. Whilst only 6% have type 1 diabetes, more than one-third need insulin to control their condition. We will now look at the background to diabetes mellitus. We will begin with classification. Diabetes mellitus is a group of metabolic diseases characterized by 1. Chronic hyperglycemia due to complete insulin deficiency, or 2. Chronic hyperglycemia due to a combination of relative insulin deficiency and diminished effectiveness of insulin, that is, insulin resistance. Classification of diabetes is based on the etiology of the disease. The World Health Organization recognizes 4 distinct types of diabetes according to the WHO in 2006. Let's begin with type 1 diabetes mellitus. This is characterized by an absolute deficiency of insulin. This complete deficiency of insulin results from selective autoimmune or idiopathic destruction of pancreatic beta cells. Whilst the condition may present at any age, it is more commonly diagnosed in childhood or early adulthood. Patients are insulin dependent and prone to ketoacidosis in the absence of insulin or during concurrent illness. Approximately 5 to 10% of people with diabetes have type 1 disease. Regarding type 2 diabetes mellitus, this is characterized by a relative deficiency of insulin or insensitivity to the effects of insulin. The condition ranges from one of predominant insulin resistance with relative insulin deficiency, to one of a predominant insulin secretory defect with some insulin resistance. It has a slower onset than type 1 disease, with a significant proportion of patients being diagnosed coincidentally. Patients are commonly, but not always, obese and are generally not prone to ketoacidosis. Maturity-onset diabetes of the young, abbreviated as MODY, presents as a type 2 process in younger patients and is due to one of a number of gene mutations. Approximately 90% of people with diabetes have type 2 disease. Next we will talk about gestational diabetes. This refers to hyperglycemia that can temporarily occur during pregnancy. It can affect between 2% and 12% of pregnancies depending on ethnic background. Gestational diabetes usually resolves postpartum, however, it increases the mother's risk of developing diabetes in later life. Regarding secondary forms of diabetes, although relatively rare, diabetes can be a feature of various hereditary and acquired diseases, as well as being drug-induced. These include disease of exocrine pancreas. This includes pancreatitis, neoplasia, cystic fibrosis, hemochromatosis, trauma or pancreatectomy. Another secondary cause can be endocrinopathies, i.e. chronic hypersecretion of hormones that antagonize insulin action. Disease states include hyperthyroidism, which involves the excessive thyroid hormone secretion, acromegaly, which involves excessive growth hormone secretion, and genetic syndromes, for example, Cushing's syndrome, which involves excessive ACTH secretion, Conn's syndrome, which involves excessive aldosterone secretion, and pheochromocytoma, which involves excessive adrenaline secretion. Infection, e.g. congenital rubella, cytomegalovirus, can also lead to secondary diabetes. drug-induced, for example, glucocorticoids, thiazides plus-minus beta blockers, nicotinic acid, diazoxide, cyclosporin, tacrolimus, atypical antipsychotics like olanzapine, clozapine, and protease inhibitors. Chronic malnutrition and liver disease, particularly cirrhosis and hepatitis, may be associated with impaired glucose tolerance and diabetes. Let's now discuss the diagnostic criteria. The UK adopts WHO criteria in patients where diabetes is suspected. A random venous blood sample should be taken to estimate glucose levels. Up to 2011, a diagnosis was usually made in one of three ways. 1. If the random venous plasma glucose is equal to or above 11.1 millimoles per liter and the patient has symptoms of hyperglycemia, e.g. polyuria, polydipsia and unexplained weight loss, the diagnosis of diabetes is confirmed. Or 2. If this test is inconclusive, the fasting plasma glucose should be measured. The venous blood sample should be collected following a fast period of at least 8 hours. If the fasting venous plasma glucose is equal to or above 7 millimoles per liter, the diagnosis is confirmed. And finally, 3. If the 2-hour venous plasma glucose is equal to or above 11.1 millimoles per liter during a 75 grams oral glucose tolerance test, a diagnosis of diabetes can be confirmed. The above criteria were extended by the World Health Organization in 2011 to include the use of HbA1c as a diagnostic test for diabetes. An HbA1c greater than 48 millimoles per mole is diagnostic for diabetes, providing that stringent quality assurance tests are in place and assays are standardized to criteria aligned to the international reference values. A value of less than 48 millimoles per mole does not exclude diabetes diagnosed using glucose tests. There is an intermediate group of people with glucose levels that do not meet the above diagnostic values but nevertheless are considered to have an increased risk of developing diabetes due to marginally raised blood glucose levels. Patients in this category also tend to have higher blood pressure and triglycerides, which ultimately increases cardiovascular risk. These patients may have either a. impaired fasting glucose abbreviated as IFG. IFG denotes an abnormally high fasting glucose concentration, falling just short of the diagnosis of diabetes. Impaired fasting glucose is defined as a fasting venous plasma glucose of equal to or above 6.1 millimoles per liter but below 7 millimoles per liter in addition to a previous random plasma glucose of below 7 millimoles per liter. It is recommended that all individuals with a positive impaired fasting glucose should have an oral glucose tolerance test to exclude the diagnosis of diabetes. Or B. Impaired glucose tolerance abbreviated as IGT. Impaired glucose tolerance can only be diagnosed on the basis of a 75 grams oral glucose tolerance test. If, following ingestion of 75 grams of oral glucose, the 120-minute venous plasma glucose is equal to or above 7.8 but below 11.1 millimoles per liter, a diagnosis of IGT is made. A glucose value of equal to or above 11.1 millimoles per liter would obviously indicate diabetes. Although capillary blood samples can be indicative of diabetes, it is important to back these up with venous blood samples assayed in the laboratory in order to confirm a diagnosis. We will now discuss glycated hemoglobin abbreviated as HbA1c. Glycated hemoglobin is formed by the non-enzymatic glycation of the N-terminal valine residue of the beta chain of red blood cell hemoglobin. The proportion of glycated hemoglobin to total hemoglobin directly reflects the degree of hyperglycemia over the previous 8 to 12 weeks. HbA.1c is the most commonly employed method of estimating glycemic control and is used to help guide therapy and predict risk of certain long-term complications of diabetes. Regarding standardization of reference range in an attempt to allow global comparison of reported values, the reference units for HbA.1c were changed from the old DCCT % units to the new IFCC, that is millimoles per mole, units on 1 June 2009. Up to 1 June 2011, in the UK, both units were reported in results. However, since 1 June 2011, only the new units are reported. Diabetes UK provides a calculator tool to allow easy conversion to the new units. See link on module web page. We will now look at target HbA1c. HbA1c in non-diabetic patients is normally below 5.8%, that is 36 millimoles per mole. Individual target HbA1c levels should be set for patients and normally will vary between 6.5%, that is 48 millimoles per mole, and 7.5%, that is 59 millimoles per mole. There is growing evidence to suggest that there is little advantage and possibly even an increased risk in aggressively controlling blood glucose to HbA1c targets of below 6.5%, 48 millimoles per mole, to 7.5%, 59 millimoles per mole. In some patients a less stringent target below 8%, 65 millimoles per mole, may be appropriate. These might include patients with a history of severe hypoglycemia, limited life expectancy, multiple comorbidities, or advanced micro or macrovascular complications. Let's now talk about multifactorial risk reduction. It is totally inappropriate to view diabetes purely as a disease that causes hyperglycemia and to target treatment with the single goal of normalizing blood glucose. The disease must be seen as one that requires multifactorial interventions to control hyperglycemia and reduce the incidence of complications. The main components of care can be remembered easily using the alphabet strategy, which is as follows. A. Advice. Structured education around self-management, concordance with treatment, physical activity, diet and weight reduction. Smoking cessation is essential. B. Blood pressure. Targets of below 130,140 systolic, 80 diastolic, depending on risk, should be met by combinations of healthy lifestyle, that is diet, weight reduction and exercise, as well as appropriate multiple pharmacological interventions if necessary. C. Cholesterol. Lipids must be checked with targets of below 4 millimoles per liter for total cholesterol and below 2 millimoles per liter for LDL cholesterol. D. Diabetes. Blood glucose control. The aim is to achieve an HbA1c target of 6.5%. It should be accepted that intensification of therapy is usually the norm in type 2 diabetes in order to offset declining insulin production. Insulin therapy in type 2 diabetes should be considered if HbA1c is constantly above 7.5% despite appropriate oral therapy. E. Eye care. Yearly digital photography of the retina is recommended with appropriate ophthalmological referral if retinopathy is present. F. Feet care. Yearly examination with appropriate referral as required. Patients must have a good understanding of how to look after their feet. G. Guardian drugs. The use of various agents to offset or treat cardiovascular disease in people with diabetes. The criteria for using aspirin in patients with diabetes are discussed in Section 5. Statins, to reduce LDL cholesterol, and ACE inhibitors to manage nephropathy are also discussed in Section 5. We will now look at managing type 1 diabetes mellitus. Let's begin with the physiological role of insulin. Insulin has wide-ranging effects on the metabolism of carbohydrates, fats and proteins. 1. It enhances cellular uptake of glucose, particularly in skeletal muscle and adipose tissue. 2. It facilitates the synthesis of energy storage molecules, that is glycogen in the liver and skeletal muscle and fat in the liver and adipose tissue, as well as inhibiting the breakdown of these molecules. 3. It promotes tissue growth and cell division by its positive effect on protein synthesis. Following ingestion, carbohydrates are broken down successively to polysaccharides, disaccharides and monosaccharides, that is glucose, fructose and galactose, which are then absorbed from the small intestine. These are transferred to the liver via the portal vein and subsequently onwards to the rest of the body. In addition, the liver has the capability of manufacturing glucose from fats and proteins. This normally occurs when there is a shortage of glucose in the circulation. Glucose in the bloodstream undergoes one of three possible immediate effects. 1. It is used directly for energy conversion. 2. It is converted to glycogen for energy storage. And 3. It is excreted in the urine. In a person without diabetes, the concentration of glucose in the bloodstream is kept within narrow limits. Following an overnight fast, it is present in concentrations approximately between 3 to 5 millimoles per liter, whilst it may rise to approximately 6 millimoles per liter following a meal. There are many hormones involved in this balancing act, of which insulin and glucagon are the most important. We will now discuss insulin release. Insulin is released from beta islet cells in the pancreas in two distinct ways. 1. There is a continuous low-level production and release to cope with the normal basal metabolic functions of the body. This varies only very slightly over a 24-hour period. 2. Following a meal, blood glucose levels begin to rise. This immediately triggers a biphasic release of insulin, i.e. an acute first phase that lasts minutes, followed by a more sustained second phase. Next we will discuss about exogenous insulin. Insulin was originally extracted and purified from the pancreas of cattle and pigs. However, human sequence or analog insulins have now largely superseded these preparations. Human insulin is manufactured by recombinant DNA technology, whilst altering the amino acid sequences of the insulin molecule produces analog insulins. These insulins vary in their absorption and activity depending on the degree of alteration to the original human insulin molecule. Insulins are most usefully described in terms of the duration of action. Short-acting insulins include 1. Soluble insulin and 2. Short-acting insulin analogs. Soluble insulin is a short-acting form of insulin. When administered subcutaneously, its onset of action is typically around 30 minutes with peak levels occurring approximately 2 hours after injection. Effects may last for 3 to 6 hours, with a total duration of action of up to 8 hours in some individuals. Soluble insulin is normally administered by subcutaneous injection. It may also be given as an IV infusion and less commonly via IM injection. Examples include 1. Human soluble insulin, marketed as Actrapid, Velocillin, Humulin S, and Insuman Rapid. 2. Animal soluble insulin, e.g. pork or bovine Hyperglycemia. Next we will discuss short-acting insulin analogs. These have a faster onset and shorter duration of action than soluble insulin. They begin to work 15 minutes after subcutaneous injection, with a peak activity around 1 to 2 hours following injection. Typically, they have a duration of action of less than 4 hours. Examples include 1. Insulin Lispro marketed as Humalog, Insulin Aspart marketed as Novorapid and Insulin Glulisine marketed as Apidra. Next we will discuss intermediate and long-acting insulins. Longer-acting insulins are generally one of two types, isophane or a long-acting analog. We will begin with isophane, that is NPH insulin. Isophane insulin is an insoluble insulin suspension created by combining insulin with protamine. This delays the absorption of the insulin, with peak blood levels appearing 6 to 10 hours after SC injection. It has a duration of action of approximately 8 to 12 hours, however this may be prolonged in some patients by up to as much as 18 hours. It is available in both human and animal variants. Examples include insulatard, humulini, insuman basal, hyperion, bovine and porcine isophane. Regarding long-acting, basal analogues, these are produced in a similar way to short-acting analogues. However, the effect here is to produce insulin which, following injection, is activated gradually. They act for up to 24 hours, producing a relatively flat profile, which reduces the amount of hypoglycemia in comparison to isophane insulins. There are two examples available at present: 1. Insulin glargine marketed as Lantus and insulin detamir marketed as Levemir. 2. Insulin degludec marketed as Reciba is a new ultra-long-acting insulin analog. Other intermediate and long-acting insulins produced by combining protamine, zinc and isophane are available, but are used very infrequently. CBNF for examples. Next we will discuss premixed or biphasic insulins. These contain a mixture of short-acting, that is either soluble or analog, and isophane or analog protamine complex. They are designed to cover both the postprandial and background insulin requirements. A comprehensive list of licensed, commercially available insulin preparations and associated devices can be found in MIMS. See link on module web page. Regarding insulin injection devices, when prescribing insulin, it is essential to state the device that the patient uses to administer the injection. As a clinical pharmacist, you should have a good understanding of the devices available and how they are used. Let's progress to type 1 diabetes mellitus. Regarding its presentation, as briefly discussed, type 1 disease is associated with a complete deficiency in insulin production and release. It has a sudden onset, normally over days to weeks, producing the following features: polydipsia, that is excessive thirst; polyuria, that is excessive urination. In addition, recent weight loss, infection and spontaneous ketosis are common and, less frequently, severe ketoacidosis. Next we will look at glycemic control in type 1 diabetes. Controlling blood glucose levels in type 1 disease encompasses a package of measures, which includes: 1. Physiological insulin replacement. 2. Measurement of blood sugars with active dose adjustment for food intake and exercise. 3. Adopting healthy lifestyle choices including appropriate diet and exercise. 4. Structured diabetes education. Physiological insulin replacement aims to mimic as closely as possible the body's normal production and release of insulin. In non-diabetic subjects there is an insulin secretory response following a meal and a continuous basal level of insulin secretion throughout a 24-hour period. The aims of insulin treatment are to: 1. To abolish symptoms. 2. To optimize blood glucose control, which avoids hypo or hyperglycemia. 3. To maintain ideal body weight. The choice of insulin and regimen used should be made on an individual basis. The National Institute for Health and Clinical Excellence Guidance CG15 Type 1 Diabetes, Diagnosis and Management of Type 1 Diabetes in Children, Young People and Adults recommends the following: 1. Prescribe the types of insulin that allow people optimal well-being. 2. Use multiple insulin injection regimens in adults who prefer them in an integrated package with education, food, skills training and appropriate self-monitoring. 3. Advise twice-daily insulin regimens. Often biphasic pre-mixes, analogues in those prone to hypoglycemia at night, for those, a. who want them, b. who find adherence to lunchtime insulin injections difficult, c. with learning difficulties who may require assistance. Let's progress to the multiple daily injections, that is the basal bolus strategy. This regimen consists of an injection of short or rapid-acting insulin before, with or immediately after each meal, that is the bolus form, plus a long-acting insulin injected once or possibly twice daily, that is the basal form. Let's discuss twice-daily injections. This regimen consists of 2 daily injections before meals, that is, usually breakfast and evening, of a biphasic mixture containing both long and short or rapid-acting insulin. And now we will move on to the continuous subcutaneous insulin infusion, abbreviated as CSII. Battery-driven syringe pumps deliver insulin via a fine plastic cannula, which terminates in a subcutaneously implanted catheter. The pump is normally worn around the waist, with the catheter sited in the abdomen. Short-acting analogues are the insulins of choice for this delivery method. Pump therapy requires motivated patients and well-resourced diabetes teams, with members specifically trained in pump therapy. This, together with the cost of therapy, has limited the introduction of continuous subcutaneous insulin infusion to a larger proportion of people with type 1 diabetes. Next we will discuss basal dose adjustment. Dose adjustment is based on titrating doses to achieve fasting blood glucose, i.e. first thing on awakening and pre-meal, levels of 4.5 to 6.0 millimoles per liter without incurring significant nocturnal hypoglycemia. Regarding mealtime dose adjustment, mealtime doses are adjusted depending on a number of factors including 1. Pre-meal blood glucose level, 2. Amount of carbohydrate to be consumed, and 3. Planned physical activity. Carbohydrate counting is of value in helping to estimate the amount of mealtime insulin required. A standard portion of carbohydrate is approximately 10 grams, and most patients begin by injecting 1 unit of short-acting analog for every 10 grams carbohydrate portion they consume. Diabetes adjustment for normal eating, abbreviated as DONI. Diabetes adjustment for normal eating is a structured education program for people with type 1 diabetes that teaches adjustment of insulin to match carbohydrate intake on a meal-by-meal basis. The course consists of 3 main areas: 1. Nutrition topics. 2. Insulin dose adjustment at mealtimes and special circumstances, exercise, or illness. 3. Other topics such as hypoglycemia, complications, sick days rules and pregnancy. Let's progress to patient education. Diabetes education for people with the condition is lifelong. On diagnosis, a fine line must be drawn between providing too much information, which confuses patients, and leaving the patient with many unanswered questions. There will never be enough time in the acute hospital setting to provide all the patient education required, so it is important to ensure that basic essential information is covered that will keep the patient safe, and that further information is provided at a pace that suits the individual. This is obviously an area where the work of diabetes nurse specialists is invaluable, providing close patient follow-up as they get to grips with their condition. Structured education programs are seen as the best way to deliver education packages to the majority of patients. They should 1. Have a structured curriculum, 2. Be provided by trained educators, 3. Be quality assured, and 4. Be audited. Essential information for patients starting on insulin includes 1. Dietary advice provided by a dietitian including planned follow-up. 2. Advice on blood glucose monitoring, recording and interpreting results. 3. Type of insulin therapy and device being used. 4. How to inject, sites and need for rotation. 5. Storage of insulin plus shots disposal. 6. Hypoglycemia, recognition and treatment. 7. Hyperglycemia, ketoacidosis and ketone analysis. 8. Foot and eye care. 9. Laws in relation to driving and informing DVLA, insurance company and employment. 10. Travel advice. 11. Identification card. 12. Hypoglycemic risk associated with alcohol. 13. Diabetes and sport, and 14. Sick day rules. Next we will progress to managing type 2 diabetes. Let's begin with the presentation of type 2 diabetes. Many patients with type 2 diabetes are diagnosed in the relatively late stages of the disease. They may have had the condition for several years and are only diagnosed once symptoms are established or secondary organ damage becomes apparent. Presenting clinical features may include 1. Minimal symptoms. Asymptomatic patients identified via screening. 2. Osmotic symptoms such as thirst, polyuria, nocturia, blurred vision, and fatigue. 3. Infection such as recurrent fungal or bacterial infection, e.g. genital candidiasis or bacterial urinary tract infection. 4. Macrovascular complications. Diagnosis is made following presentation with cardiovascular disease, e.g. acute coronary syndromes, transient ischemic attack or stroke, intermittent claudication, and ischemic ulceration. 5. Microvascular complications such as retinopathy, nephropathy, neuropathy. Type 2 diabetes develops due to a progressive deterioration of islet beta cell function coupled with increasing insulin resistance for which the beta cell cannot compensate. At the time of diagnosis, beta cell function is already reduced and continues to deteriorate, regardless of therapy. The condition is heterogeneous, ranging from predominantly insulin resistance with relative insulin deficiency to predominantly insulin deficiency with little or no insulin resistance. Next we will look at insulin resistance and the metabolic syndrome. Insulin resistance is often associated with a clustering of features collectively known as the metabolic syndrome. These consist of impaired glucose tolerance, central obesity, hypertension, accelerated atherosclerosis, low serum high-density lipoprotein, abbreviated as HDL cholesterol, and raised triglycerides. Metabolic syndrome is considered to be a state of heightened cardiovascular risk. We will now discuss the management of type 2 diabetes. Effective management of diabetes cannot be achieved without an appropriate diet. People with diabetes must be encouraged to adopt healthy food choices and should receive structured education that deals with all aspects of the disease as early as possible following diagnosis. On initial diagnosis of asymptomatic patients, dietary and lifestyle changes should be employed for a period of at least 1 month and preferably up to 3 months before assessing HbA1c to ascertain the need for oral therapy. The United Kingdom Prospective Diabetes Study Group, abbreviated as UKPDS, demonstrated that only 16% of newly diagnosed people with type 2 diabetes achieved normal blood glucose control after 3 months of lifestyle modification. In addition, it should be noted that it is common to prescribe oral hypoglycemic agents, abbreviated as OHAS, at diagnosis, especially if the patient is symptomatic or is displaying any signs of complications. We will now look at treatment targets. Introduction and escalation of therapy is driven by assessment of HbA1c and associated symptoms in addition to identified complications. A target of 6.5% is the gold standard, however targets need to be managed on an individual basis. Type 2 diabetes is characterized by a progressive increase in hyperglycemia with time, principally due to deterioration in beta cell function, irrespective of what treatments are used. The result is that most people with type 2 diabetes eventually require multiple therapies to control their blood glucose. The stepwise approach to maintaining glycemic control is detailed within NICE Clinical Guideline 87, May 2009. We will move on to drug treatment. Let's begin with metformin. Metformin is considered to be the first-line treatment for all patients. It can be combined with any other class of OHA or with insulin. Benefits of metformin therapy include 1. Negligible chance of inducing hypoglycemia. 2. It can be combined with all other OHAs or insulin. 3. Proven to reduce risk of myocardial infarction according to the UKPDS-38 trial. 4. Low cost. 5. Does not cause weight gain and may promote weight loss. Regarding the mode of action of metformin, although not completely understood, metformin is thought to exert its glucose-lowering effect by altering several metabolic pathways including 1. Reduction of excessive hepatic glucose production. This is the principal mode of action. 2. Increases insulin-mediated glucose uptake in fat and adipose tissues. 3. Decreases fatty acid oxidation. And 4. Increases glucose turnover in all main abdominal organs. Next we will talk about cautions and contraindications of metformin use. These include renal and hepatic disease, cardiac or respiratory disease or any other hypoxic condition, severe infection, alcohol abuse, history of acidosis, use of intravenous radiographic contrast media, general surgery. It is recommended that metformin should be discontinued once eGFR is equal to or below 30 ml per minute per 1.73 meters squared or serum creatinine rises in excess of 150 micromoles per liter, although many diabetologists would argue that this is a little overcautious. Regarding its side effects, the principal undesirable effect is gastrointestinal upset including nausea, diarrhea, and a metallic taste. Metformin may also reduce the absorption of vitamin B12. There is a very rare risk of lactic acidosis, which increases if the drug is used in situations known to evoke the condition. See cautions and contraindications above. We will now progress to drug interactions. The only significant drug interaction occurs with cimetidine as both are eliminated by tubular secretion within the kidney. This can lead to an accumulation of metformin. Regarding dose and formulations, initial doses should be low, e.g. 500 mg or 850 mg daily with food to maximize tolerability. This can be increased after a few days or weeks. Doses typically range from 1.5 to 3 grams daily in divided doses, although very few clinicians exceed 2 grams daily. Controlled release formulations are available for restricted indications. In 2009, the Scottish Medicines Consortium, abbreviated as SMC, accepted metformin MR for restricted use in the treatment of patients with type 2 diabetes mellitus, when dietary management and exercise alone does not result in adequate glycemic control. We will now progress to sulfonylureas, abbreviated as SUS. These agents can be used as first-line agents in patients with type 2 disease who cannot tolerate metformin or in whom metformin is unsuitable. They effectively lower blood glucose levels, however his effect relies on some degree of islet cell function. Unlike metformin, they can cause significant marked hypoglycemia and may induce weight gain. They can be combined with any other OHA providing it does not induce insulin secretion. They may also be combined with insulin. Regarding their mode of action, these agents work by direct stimulation of functionally capable beta cells, causing release of insulin. As beta cell function deteriorates over time, the efficacy of these agents will also reduce. Regarding their side effects, prolonged and severe hypoglycemia can occur with sulfonylureas. This is particularly true of the longer-acting agents with active metabolites, e.g. glibenclamide and chlorpropamide. These agents are no longer recommended in elderly patients due to this effect. Sulfonylureas may cause weight gain. This is not so much a side effect but more the result of improved glycemic control stopping the excretion of glucose in urine, combined with the anabolic effects of augmented insulin production. Other side effects include GI upset and derangement in liver function, leading rarely to cholestatic jaundice, hepatitis and liver failure. Allergic skin reactions have also been reported. We will now discuss cautions and contraindications to sulfonylurea use. Caution is required when prescribing these agents in mild to moderate hepatic and renal impairment. Gliclazide and glipizide are suitable agents if mild renal impairment is present. These agents are contraindicated in severe hepatic or renal impairment, porphyria, pregnancy and breastfeeding. We will now discuss meglutininide analogues. Meglutininide analogues, also known as prandial glucose regulators abbreviated as PGRs, produce a rapid but short-lived stimulation of insulin secretion. They are deployed to augment the first-phase insulin release following ingestion of carbohydrate, thus helping to control post-prandial glucose levels. They are taken within 30 minutes before food and are avoided if a meal is missed. Repaglinide and nataglinide are the two meglutinides currently available in the UK. These agents may be of benefit for individuals with an erratic lifestyle in which meals are regularly missed. Regarding their cautions and contraindications, they should be used with caution in patients with hepatic or severe renal disease. Regarding their side effects, despite the short duration of action, hypoglycemia is the main side effect. Next we will progress to thiazolidinediones, also known as the glitazones. These agents improve insulin sensitivity by stimulating a nuclear receptor known as the peroxisome proliferator activated receptor gamma, abbreviated as PPAR-gamma. Glitazones, like metformin, require the presence of insulin to generate significant blood glucose-lowering effects. It may take several weeks for the optimum effect of this therapy to become apparent. Pioglitazone is the only glitazone currently licensed in the UK. In September 2010, the European Medicines Agency, abbreviated as EMA, the body responsible for monitoring the safety of medicines, recommended the suspension of the marketing authorization for rosiglitazone. They concluded that due to associated cardiovascular adverse events, the benefits of rosiglitazone no longer outweighed its risks. EMA 2010. Regarding their place in therapy, although licensed as monotherapy, glitazones should only be used first-line when metformin, sulfonylureas or both fail to maintain adequate glycemic control, are inappropriate or are poorly tolerated. The combination with metformin is preferred in obese patients. It should be noted that triple therapy with metformin, a sulfonylurea and a glitazone should not delay the introduction of insulin in patients who clearly need it. However, there is justification for using this regimen in patients with significant insulin resistance or for those who are reluctant to use insulin due to employment or other reasons. In line with NICE recommendations, pioglitazone may be considered in addition to insulin in patients who display significant insulin resistance. NICE CG 87, 2009. However, this combination increases the risk of fluid retention, potentially leading to heart failure. Regarding their cautions and contraindications, NICE recommend not to commence or continue a thiazolidinedione in people who have heart failure, or who are at higher risk of fracture. In addition, they are contraindicated in hepatic impairment. Pre-treatment and periodical assessment of liver function is essential. Pioglitazone also marginally increases the risk of bladder cancer and should not be used in patients with a history of or are at increased risk of developing this condition. Regarding their side effects, these include gastrointestinal disturbances, weight gain, edema, anemia, headache, hypoglycemia and an increase in fracture risk. We will now progress to the alpha-glucosidase inhibitors. These agents slow the rate of carbohydrate digestion by blocking the activity of alpha-glucosidase enzymes located in the brush border lining of the intestinal villi. They effectively slow down the postprandial rise in glycemia seen in patients with type 2 diabetes. The only available licensed agent in the UK is acarbose. They may be considered for a person unable to use other oral glucose-lowering medications. NICE CG 87, 2009. Regarding their side effects, the main side effect of acarbose is gastrointestinal upset, e.g. flatulence, abdominal pain and diarrhea. Isolated cases of liver dysfunction have been reported with this drug. Regarding the dosing schedule, the starting dose is 50 mg daily initially, increasing to 50 mg 3 times daily, with main meals. This can be gradually increased to a maximum of 200 mg 3 times daily. We will now progress to the incretin mimetics. Incretins are gastrointestinal hormones involved in the complex regulation of glucose homeostasis via their modulating effects on insulin and glucagon secretion. There are many incretin hormones, but the principal agents are glucagon-like peptide-1 abbreviated as GLP-1 and glucose-dependent insulinotropic polypeptide abbreviated as GIP. They are secreted following meal ingestion. Their effects include 1. An increase in insulin secretion in a glucose-dependent manner. 2. Glucose-dependent suppression of glucagon. 3. Deceleration of gastric emptying. And 4. Improved feeling of satiety. This incretin effect is known to be attenuated in type 2 diabetes. GLP-1 and GIP are both rapidly inactivated by the enzyme dipeptidyl peptidase 4, abbreviated as DPP4. The pharmaceutical agents that target these pathways can be subdivided into two distinct categories. 1. GLP-1 analogues bind to, and activate, the GLP-1 glucagon-like peptide-1 receptor to increase insulin secretion, suppress glucagon secretion, and slow gastric emptying. 2. DPP-4 inhibitors inhibit DIPEPTIDYLPEPTIDASE4 to increase insulin secretion and lower glucagon secretion. As this is a relatively new and evolving therapeutic area for type 2 diabetes management, please refer to the current BNF for UK licensed agents and the dosing schedules. Let's progress to sodium glucose cotransporter 2 abbreviated as SGLT2 inhibitors. Dapagliflozin is the first to market SGLT2 inhibitor for the treatment of hyperglycemia in diabetes. SGLT2 is selectively expressed in the kidney and is responsible for the reabsorption of glucose from glomerular filtrate back into the circulation. By reducing this reabsorption, SGLT2 inhibitors promote urinary glucose excretion, therefore reducing circulating glucose levels. We will now progress to insulin therapy in type 2 diabetes. Type 2 diabetes is generally regarded as a progressive disorder with deterioration in beta cell function over time. This manifests as an inability to maintain glucose control despite intensifying therapy. Many patients will ultimately require insulin to control hyperglycemic symptoms, improve quality of life and maximize glycemic control. Any patient failing to maintain an HbA1c below 7.5% on dual or triple therapy should be assessed in relation to the risks and benefits of insulin treatment. Any decision on insulin therapy should be made in consultation with each patient on an individual basis. We will now progress to insulin initiation. There are a number of clinical indications for commencing insulin in type 2 diabetes. These include 1. Persistent hyperglycemia with or without symptoms on maximum OHAS. 2. Short-term insulin used to manage acute illness or surgery. 3. Pre-planned pregnancy. Commonly employed insulin regimens for patients with type 2 diabetes at 1. A single daily dose of intermediate or long-acting insulin either alone or combined with metformin or sulfonylurea or both. 2. Twice daily pre-mixed combinations of short and intermediate-acting insulin either alone or combined with metformin or sulfonylurea or both. 3. Basal bolus regimen with or without metformin. All these regimens will improve glycemic control providing the insulin doses are actively titrated to achieve target blood glucose levels. Single daily dose regimens are good starting regimens and may be intensified to twice daily pre-mixed or even mealtime plus basal regimens if required. Obviously, this titration must be balanced against the risk of inducing hypoglycemia coupled with the need to avoid significant weight gain in a population that is already predominantly overweight. It may be necessary to accept less than perfect glycemic control in order to prevent potentially catastrophic hypoglycemic episodes, e.g. in the elderly, socially isolated, or patients with significant dementia. Unfortunately, there is no simple way to predict an individual's insulin requirements. This is due to the varying degrees of insulin resistance in patients with type 2 diabetes. We will now discuss diet and diabetes. There are powerful epidemiological associations between being overweight and developing type 2 diabetes. The risk of developing type 2 diabetes increases as the BMI rises above 23 kg per meter squared. Weight gain in adulthood is a significant risk factor. It is estimated that above 65% of people with type 2 diabetes are overweight or obese. The health benefits associated with a 10% weight loss in a 100 kg patient are shown in Table 1. Effective management of diabetes cannot be achieved without an appropriate diet. Newly diagnosed patients should have counseling from a dietitian within 4 weeks of diagnosis. First-line interventions for type 2 diabetes include 1. Diet modification, 2. Exercise and physical activity, and 3. Behavioral modification. Pharmacological treatments, such as orlistat, are second-line agents and should be used according to NICE guidance, NICE CG 43, obesity. We will now progress to patient education for type 2 diabetes. The cornerstone for management of type 2 diabetes is effective self-management. A structured education program will provide patients with the skills and knowledge they require to manage their condition effectively, ultimately improving patient outcomes. National Collaborating Center for Chronic Conditions 2008 Type 2 Diabetes, National Clinical Guideline for the Management in Primary and Secondary Care. London, Royal College of Physicians. NICE recommends that structured education should be offered at diagnosis with annual reinforcement, CG 66. 2 of the programs delivered to people in Northern Ireland with type 2 diabetes are Desmond, www.desmond-project.org.uk, Expert, www.expertpatients.co.uk. Let's progress to managing acute complications in hospital. We will begin with hypoglycemia. For treatment purposes, any blood glucose level below 4 mmol per liter is regarded as hypoglycemia. Hypoglycemic events are normally divided into 1. Mild, successfully treated by the patient. 2. Severe, requiring the assistance of others to treat. The crucial point to realize is that hypoglycemia will not resolve itself and requires intervention to prevent it from worsening. Warning symptoms. These may be divided into 2 categories: adrenergic, caused by activation of the sympatho-adrenal system. Typical symptoms include tremor, sweating, anxiety, pallor, nausea, tachycardia, palpitations and shivering. These are also referred to as early warning signs. Neuroglycopenic, resulting from inadequate cerebral glucose delivery. Typical signs and symptoms include impaired concentration, confusion, irrational behavior, slurred speech, drowsiness, coma, convulsions, permanent neurological damage if prolonged severe hypoglycemia. Neuroglycopenic signs and symptoms occur at lower blood glucose levels than adrenergic symptoms. Regarding treatment, as already stated, it is vital to treat hypoglycemia in order to prevent it from worsening. Many hospital pharmacies supply wards with a hypo kit, which contains the various agents required to treat hypoglycemia. It is important to ascertain the cause of the hypoglycemia in order to treat it appropriately and to try to prevent reoccurrence. Typical causes of hypoglycemia include 1. Mismatch between carbohydrate consumption, insulin administration and activity levels. 2. Overdose of insulin or sulfonylureas. 3. Inadvertent injection of insulin via a rapidly absorbed route, normally IM. 4. Activity that results in increased rates of insulin absorption, e.g. injection into the thigh followed by a period of intense muscle activity, hot bath or in a hot climate. 5. Excess alcohol consumption, the night before. The above treatment guideline gives examples of how to treat hypoglycemia in a range of hospitalized patients. We will now progress to diabetic ketoacidosis. Diabetic ketoacidosis, abbreviated as DKA, normally occurs in patients with type 1 diabetes and may indeed be the presenting diagnosis of some patients with type 1 disease. Although general guidelines are available for treatment, it is important to tailor these to the needs of the individual patient. Regarding the precipitating causes, these include conditions that increase circulating levels of stress hormones, such as infection, myocardial infarction or surgical emergencies. Errors in insulin administration or deliberate omission are also common causes of diabetic ketoacidosis. Regarding its signs and symptoms, the symptoms of polyuria and polydipsia reflect hyperglycemia, but the important symptoms of vomiting, abdominal pain and/or shortness of breath indicate the likelihood of ketoacidosis. Symptoms of any precipitating condition may also be present. Non-specific signs of diabetic ketoacidosis include tachycardia, dehydration, hypotension, hyperventilation, Kussmaul respiration, reduced level of consciousness and ketone odor on the breath. Let's now progress to the criteria for diagnosis. These include 1. Raised, that is above 11.1 mmol per liter blood glucose, or known diabetic. 2. Ketonuria 2+ or more on urine dipstick tests, or above 3 mmol per liter ketonemia. 3. Significant acidosis, venous blood pH of less than 7.3 or serum venous bicarbonate level of below 15 mmol per liter. Indicators of severe ketoacidosis include 1. Venous bicarbonate below 5 mmol per liter. 2. Ketonemia above 6 mmol per liter. 3. Venous blood pH below 7.1. 4. Hyperventilation. 5. Hypotension, systolic below 90 mm of mercury. And 6. Reduced level of consciousness. Let's now progress to its management. The above guideline advocated changes in the way that some aspects of treatment had been managed previously. This includes 1. Measure venous rather than arterial bicarbonate and pH. 2. Blood ketone meters should be used for near-patient testing. 3. Crystalloid rather than colloid solutions are recommended for fluid resuscitation. 4. Cautious fluid replacement in young adults. 5. 0.9% sodium chloride solution is the recommended fluid of choice. 6. Subcutaneous long-acting analog insulin should be continued. 7. Insulin should be administered IV at a fixed rate, calculated on body weight. 8. Do not use a priming dose bolus of insulin. 9. Bicarbonate administration is not recommended routinely. 10. Phosphate should not be supplemented routinely. Management should not be delayed as this increases the risk of a fatal outcome. Mild DKA can be managed adequately on general medical wards, however more severe ketoacidosis warrants HDU or ITU admission. Standard management focuses on insulin administration, fluid replacement and correction of electrolyte abnormalities, in addition to establishing and treating the underlying cause. The patient must be risk assessed for thromboprophylaxis. Regarding fluid replacement, this should be rapid initially and adjusted according to the patient's response and any comorbidity. Strict fluid balance is essential, requiring urinary catheterization if the patient is incontinent or has had no output after 2 hours of fluids. A central venous pressure (CVP) line will help to guide fluid management in those patients at a high risk of fluid overload, e.g. elderly, coexisting heart failure or significant renal impairment. A typical fluid replacement regimen would be as illustrated in the table below. Pause the video and carefully scrutinize the table before advancing to the next slide. Continuous IV insulin infusion is now accepted as the standard mode of delivering insulin during episodes of DKA. This infusion provides sufficient levels of insulin in the blood to prevent gluconeogenesis by the liver, which is the key to correcting ketone body production and acidosis. The above guidelines advocate using a fixed-rate IV insulin infusion of 0.1 units per kilogram per hour, but many units within Northern Ireland use an intravenous sliding scale such as that described in the treatment of hyperglycemic hyperosmolar syndrome. Whichever method is used, there should be clear guidelines for staff to follow. Regarding potassium, most patients will be potassium depleted and serum potassium will fall as acidosis is corrected. IV fluids containing varying amounts of potassium should be used depending on measured serum potassium. A typical potassium replacement schedule is described below. Pause the video and carefully scrutinize the table below. The JBDSICP guideline advocates a simpler replacement regimen in that 40 mmol per liter is given to patients with a serum potassium of between 3.5 and 5.5. Regarding bicarbonate, bicarbonate is usually unnecessary and may be harmful, causing an increased risk of hyperkalemia, cerebral edema and potential extravasation injuries if given peripherally. It should only be considered if pH is below 6.9 and should only be given under specialist direction. Regarding phosphate, hypophosphatemia may occur in DKA, as in many other metabolic disturbances, and may persist for several days. Prospective studies have failed to demonstrate any clinical benefit from phosphate replacement. However, it may be considered in patients with cardiac dysfunction, anemia or respiratory depression where muscle weakness associated with hypophosphatemia may complicate recovery. Regarding anomalies, 1. A raised white cell count is common in DKA and does not necessarily indicate infection. 2. Fever may be absent initially because of acidotic vasodilatation. And 3. Serum amylase is often elevated and does not necessarily indicate pancreatitis. Regarding monitoring, capillary blood glucose should be measured hourly, and backed up by venous samples every 2 hours, until the patient stabilizes and then as appropriate. Urea and electrolytes should be measured initially, then after 2 hours and 4 hourly until stable. Serum potassium needs to be measured frequently to help estimate potassium replacement. Regarding continuing management, patients can be transferred back to their normal insulin regimen, if appropriate, once they're eating and drinking, pH is normalizing and ketones are almost absent. The insulin infusion should be stopped shortly after commencing subcutaneous insulin injection, that is 15 to 30 minutes. The hospital diabetes team must be informed to allow them to review insulin regimens, review trigger factors and provide patient education, e.g., sick day rules. Let's progress to DKA in children and young adults. Treatment of DKA in children and young adults up to typically 18 years provides significant challenges with respect to meticulous rehydration and electrolyte correction. The British Society for Paediatric Endocrinology and Diabetes, abbreviated as BSPED, has produced guidelines that are considered best practice in this area. Let's now progress to hyperosmolar hyperglycemic state, abbreviated as HHS. Hyperosmolar hyperglycemic state, formerly described as hyperosmolar non-ketotic coma, abbreviated as HONC, is a life-threatening emergency characterized by significant hyperglycemia, that is, blood glucose levels of above 50 mmol per liter are not uncommon, and high plasma osmolality with potentially only a minor degree of ketosis and acidosis, that is, an arterial pH above 7.3. It is much less common than DKA, and now we will discuss its clinical characteristics. Hyperosmolar hyperglycemic state typically presents in the elderly and may be the first presentation of type 2 diabetes. Severe dehydration and pre-renal failure are common. Like DKA, it is necessary to look for precipitating causes, e.g. myocardial infarction, sepsis, etc. Cerebral edema is the most serious complication, presenting as seizures, progressive confusion, altered consciousness and leading to permanent neurological damage or death. Table 2 provides a comparison of DKA and hyperosmolar hyperglycemic state in biochemical terms. Pause the video and carefully scrutinize Table 2 summarizing the biochemical comparison of DKA and HHS. Symptoms may develop over days to weeks. These include polyuria, polydipsia, polyphagia, weight loss, vomiting, dehydration, peripheral vasodilation, weakness and significant reductions in consciousness level. Regarding investigations include urea plus electrolytes, glucose, ABGs, urinalysis, full blood count, serum bicarbonate, plasma osmolality, blood and urine cultures, chest X-ray, amylase, ECG and troponins. Precipitating causes include infection, MI, and certain drugs, e.g. glucocorticoids, diuretics, phenytoin, cimetidine and atypical antipsychotics. Thromboembolic complications are common and anticoagulation with low molecular weight heparin should be initiated, providing there are no contraindications. Regarding treatment, generally, most patients require HDU or ICU admission with appropriate airway management and central venous pressure monitoring to optimize fluid replacement. Regarding fluid replacement must be matched to the individual. A suggested regimen is shown in the table below. Pause the video and carefully scrutinize the table. Plasma osmolality may be calculated by the formula 2 times into brackets sodium plus potassium concentrations closed brackets plus urea plus glucose if urgently required before a lab result is available. Regarding serum sodium levels, severe hyperglycemia causes fluid shifts out of cells and a fall in sodium levels by dilution. As hyperglycemia is corrected, there will usually be a rise in serum sodium. This rise is to be expected, although it is not an indication in itself to switch treatment to hypertonic fluids, as this will increase the risk of cerebral edema. If serum sodium is above 155 mmol per liter, 0.45% sodium chloride should be used with caution and giving more than a liter is not recommended. Regarding potassium replacement, this is similar to the treatment recommended for DKA. Regarding insulin, patients with HSS seem to be quite sensitive to the effects of insulin, so it may be necessary to use less insulin than required in DKA patients. The treatment of choice remains an IV infusion of soluble insulin. Regarding monitoring, 1. Meticulous fluid balance monitoring is essential. And 2. Monitor hourly capillary blood glucose with observations until stable, then 2 to 4 hourly. Regarding continuing treatment, most patients can eventually be managed with OHs and diet, however, recovery of insulin secretion may take time and insulin may be required for a few weeks. Insulin may be required indefinitely in some patients following HHS. Let's transition to glycemic control during periods of hospital admission. It is widely accepted that hyperglycemia in hospitalized patients is associated with poorer outcomes. There is less consensus with respect to what target levels of glycemic control should be aimed for, or in which particular patient populations. The control of hyperglycemia during periods of hospitalization has been most extensively studied within the field of critical care. The conclusion that tight glycemic control improved mortality outcomes in critically ill patients led to tight glycemic control targets being introduced for the management of critically ill patients, as published by Van den Berger and colleagues in 2001. However, a meta-analysis in 2008 has raised some doubt over this approach, as it reported that tight glycemic control was not associated with significantly reduced mortality. A further study, reported in 2009, in critically ill patients demonstrated that tight glycemic control compared with conventional control actually increased mortality. Nice Sugar Study Investigators, 2009. In response to this growing uncertainty, a consensus statement has been issued by the American Diabetes Association and the American Association of Clinical Endocrinologists. It advocates the use of IV insulin to control blood sugars if they are persistently above 10 mmol per liter, aiming for a target of between 7.8 mmol per liter and 10 mmol per liter in critical care patients, as published by Mohisi and colleagues in 2009. The consensus statement accepts there is very little existing evidence to guide recommendations for target blood glucose levels in non-critical care patients, i.e. those found in general medical or surgical wards. For these patients, it specifies pre-mel targets of below 7.8 mmol per liter and random levels below 10 mmol per liter, providing these can be attained safely. Insulin is considered to be the most appropriate therapeutic agent to control acute hyperglycemia. The use of insulin provides the greatest flexibility to try to meet glycemic targets within the hospital setting and is preferred to oral agents in managing acute hyperglycemia. Intravenous soluble insulin infusions are widely employed to control blood glucose levels in the following settings: 1. Critical care illness. 2. Patients nil by mouth. 3. Type 1 diabetes. 4. Pre-operative, intraoperative and postoperative settings. And 5. DKA and HHS. For patients managed in non-critical care areas, the use of subcutaneous insulin regimens with a basal, mealtime and correction component are advocated. Subcutaneous sliding-scale insulin, abbreviated as SSI, is commonly used as the correction component, but this should not routinely be the sole insulin replacement regimen. Unfortunately, this practice is still very common in most Northern Ireland hospitals. With such a potent drug like insulin, it is imperative that appropriate monitoring protocols are in place to maximize the benefit whilst also minimizing the risk of adverse events due to poorly managed insulin administration and blood glucose monitoring. Inpatients receiving insulin should have their blood glucose checked a minimum of 4 times per day, with appropriate action taken to correct either hypo or hyperglycemia. Let's now transit to diabetes and surgery. Patients with diabetes who are undergoing surgery present specific challenges to the healthcare team. They run an increased risk of developing complications due to possible altered renal and cardiovascular function, as well as being more susceptible to infection and delayed wound healing. As stated above, meticulous glycemic control reduces morbidity and mortality within several surgical settings. Regarding management plans, in the case of non-insulin-treated patients with diet-controlled type 2 diabetes do not normally require any specific intervention before surgery. Patients taking oral hypoglycemic agents and GLP-1 agonists should withhold the dose on the morning of surgery. Metformin should be withheld on the morning of surgery for most minor procedures. If major surgery employing the need for iodinated contrast media is planned, or renal function is impaired, metformin should be withheld 48 hours pre- and post-procedure to minimize the risk of lactic acidosis. A combination of insulin, glucose and potassium can be used to maintain glycemic control during the perioperative period, see below. Among insulin-treated patients, patients using basal bolus regimens should maintain basal insulin requirements and omit their morning mealtime dose. For minor procedures, providing these patients are placed first on the list, they should normally be eating again by lunchtime and can then resume mealtime injections. Patients who use twice-daily injections should omit the injection on the morning of the procedure. If eating again at lunchtime, many centers recommend giving approximately 50% of the normal morning dose at lunchtime. Patients who require major procedures or who are hyperglycemic should be managed with intravenous insulin infusions. A typical management plan for the day of surgery would include 1. Omit breakfast. 2. Omit morning subcutaneous insulin dose. 3. Commence an intravenous infusion of 5 to 10% glucose with potassium and give at a rate that matches fluid requirements. And 4. Prepare a 50 units per 50 ml soluble insulin in 0.9% sodium chloride infusion and administer via syringe pump. The rate of the insulin infusion should be adjusted according to blood glucose levels. A typical rate adjustment protocol is provided in Table 3 below. Pause the video and carefully scrutinize the table before advancing to the next slide. Blood glucose should be measured hourly until stable, then every 2 hours. A switch back to subcutaneous insulin may be attempted once the patient is eating and drinking. Notes: 1. The insulin infusion should be stopped approximately 30 minutes after subcutaneous injection of mealtime insulin. 2. Doses may need to be increased by 10 to 20% due to increased levels of stress hormones and physical inactivity. 3. Consideration must be given to the degree of insulin resistance when initially deciding on the IV infusion sliding scale. 4. An alternate sliding scale will need to be employed for severely insulin-resistant patients. Let's transit to long-term complications of diabetes. Evidence from the Diabetes Control and Complications Trial Research Group, abbreviated as DCCT, and the United Kingdom Prospective Diabetes Study, abbreviated as UKPDS, suggests that the majority of complications associated with diabetes are to a large extent preventable. However, it is also true that a minority of people with diabetes develop devastating complications despite being reasonably well controlled. On a basic level, long-term complications from diabetes result from damage caused to different types of blood vessels, i.e. microvascular and macrovascular. These complications may be accelerated by the presence and severity of associated risk factors. We will now look at microvascular complications. The small vessel, that is microvascular, complications of diabetes primarily affect the following: 1. Retina, 2. Renal glomerulus, and 3. Peripheral nervous system. All of these tissues are freely permeable to glucose, and complications are closely linked to glycemic control. UKPDS demonstrated that each 1% reduction in HbA1c for 10 years was associated with a 37% reduction in microvascular complications. The ultimate clinical consequences of microvascular disease include visual impairment, chronic renal failure, and neuropathic foot ulceration. Visual impairment. Visual complications associated with diabetes include: 1. Transient visual disturbances associated with osmotic changes secondary to fluctuations in blood glucose levels. 2. Retinopathy, which is responsible for greater than 80% of blindness in people with diabetes. 3. Cataracts, which develop earlier in people with diabetes. 4. Glaucoma, either primary or secondary to retinopathy. Poor glycemic control and hypertension are the major risk factors associated with progression of retinopathy in people with diabetes. Next we will discuss chronic renal disease. Diabetic nephropathy is the single largest cause of end-stage renal disease in Western countries and is responsible for more than one-third of all patients commencing renal replacement therapy. In addition, it is closely associated with increased morbidity and mortality from subsequent cardiovascular disease. Thus, diabetic nephropathy, in common with other forms of chronic renal disease, may be regarded as a state of greatly accelerated atherosclerosis. As diabetic nephropathy progresses, it is closely linked with the presence of hypertension, retinopathy, neuropathy and hyperlipidemia, as well as cardiovascular disease. NICE Clinical Guidelines CG 15, 2004. Diabetic nephropathy is characterized by pathological changes in the glomeruli and renal tubules, leading to ever-increasing losses of protein, mostly albumin, and deterioration in the glomerular filtration rate (GFR). Serum creatinine does not increase until the GFR has fallen by 50 to 70%. Once serum creatinine begins to rise, renal referral is appropriate in order to maximize treatment and to monitor renal function in order to predict if and when renal replacement therapy is required. Renal replacement therapy is necessary once the serum creatinine reaches approximately 500 micromoles per liter. Table 4 summarizes the biochemical progression of diabetic nephropathy. Pause the video and carefully scrutinize the table summarizing the stages of chronic kidney disease. Proteinuria is best quantified by measuring the albumin excretion rate in timed urine collections. A much more convenient method is to measure the urine albumin-creatinine ratio, abbreviated as ACR, from an early morning urine sample. ACR values are defined in Table 5. Urinary ACR may be influenced by several factors including, 1. Hyperglycemia, 2. Urinary tract infection, 3. Congestive heart failure, 4. Exercise, 5. Aging, and 6. Other renal pathology. Table 5 summarizes definitions of abnormal urinary albumin excretion. Pause the video and carefully scrutinize the table before advancing to the next slide. Regarding its management, the key message in management of microvascular complications is to prevent or slow their progression by aggressive risk factor management, as published in the Drug and Therapeutics Bulletin, in June 2005. Both improved glycemic and blood pressure control have been demonstrated to reduce the incidence of microalbuminuria in people with diabetes. Once microalbuminuria is present, there is clear evidence that aggressive blood pressure control target below 130 systolic 80 diastolic slows the progression to overt proteinuria. NICE recommends that all people with microalbuminuria or proteinuria should be treated with an ACE inhibitor or angiotensin II receptor antagonist, abbreviated as ARA, even if the BP is normal. Regarding glycemic control, insulin is often the treatment of choice, however doses may require careful adjustment as renal impairment progresses. Sulfonylurea agents, particularly long-acting agents, e.g. glibenclamide, should be avoided. Shorter-acting agents, e.g. gliclazide, are suitable in the early stages of disease. Deteriorating renal function in itself increases the risk of lactic acidosis, so it is important to consider the extra risk associated with metformin therapy. It is recommended that metformin is discontinued once serum creatinine above 125 to 150 micromoles per liter, that is an eGFR below 30 milliliters per minute. Regarding blood pressure control, while blood pressure control may be more important than the types of agents used to achieve it, some differences between classes of agents have been noted. There is a wealth of evidence to support the use of ACE inhibitors, both to prevent microalbuminuria in normotensive patients, and slow progression of diabetic nephropathy in patients with microalbuminuria. The evidence is more convincing for patients with type 1 as opposed to type 2 diabetes. That is the HOPE study, of 2000. ACE inhibitors should be used first line with substitution by angiotensin II receptor antagonists if poorly tolerated. It is almost always necessary to use multiple agents to control blood pressure in hypertensive patients with nephropathy. Hyperkalemia is a major hazard in patients with nephropathy who take potassium-sparing drugs, e.g. ACE inhibitors, angiotensin II receptor antagonists and spironolactone, and requires careful monitoring of potassium levels. Careful monitoring of renal function is necessary after each dose titration with ACE inhibitors, angiotensin II receptor antagonists and loop diuretics. Regarding smoking cessation, patients with nephropathy must be strongly advised to stop smoking. Continuation further increases the already grossly elevated cardiovascular risk associated with nephropathy. Regarding neuropathy, neuropathy is the most common chronic complication of diabetes, affecting up to 50% of patients with type 1 and type 2 diabetes. It is thought that neuropathies arise from the effects of chronic hyperglycemia on both nervous tissue and the blood vessels that supply it. Basically, neuropathies can be classified as either 1. Peripheral, the most common include problems with legs and feet, and carpal tunnel syndrome. Or 2. Autonomic, affecting the autonomic nervous system. These neuropathies can affect many organs. Principal examples include erectile dysfunction in males. There is also a macrovascular component to this condition, excessive sweating, diarrhea, gastroparesis and postural hypotension. Regarding neuropathic foot, nerve damage in the foot of a person with diabetes results in a warm, numb, dry and usually painless foot, with palpable pulses. As this progresses, changes to the architecture of the foot can occur, with abnormal pressure distribution leading to ulceration. Regarding ischemic foot, which is a macrovascular complication, damage to the circulation leads to feet being cold and painful with absent pulses. Pain may be of the intermittent claudication type on walking or may develop into rest pain in later stages. As this develops, it can lead to 1. Ischemic ulcer. This results from local pressure on a poorly perfused area. The resulting hypoxia causes tissues to break down, resulting in ulceration. 2. Cyanosis. Feet become increasingly cold and purplish in color. And 3. Necrosis. Circulation becomes so poor that tissue becomes necrotic and amputation may be required. Many patients with diabetes-related foot problems have both a neuropathic and ischemic component. Patients most at risk of developing diabetic foot complications are 1. Elderly. 2. Poorly controlled type 2 diabetes. And 3. Long-standing type 1 diabetes. We will now discuss the treatment of neuropathic pain. There are several interventions that can be employed to help treat neuropathic pain. These include 1. Maximizing glycemic control, 2. Maintaining ideal body weight, 3. NICE recommend duloxetine or amitriptyline if duloxetine is contraindicated, as first line in the management of pain associated with diabetic neuropathic pain. 4. Tricyclic antidepressants may help control burning neuropathic pain, and 5. Anticonvulsants can be used to control shooting pains associated with neuropathy. We will now discuss foot care advice. People with diabetes require appropriate advice in relation to caring for their feet. Some basic rules are described below. 1. Inspect feet daily, or have someone else inspect them. 2. Check footwear for foreign objects before use. 3. Have feet measured carefully when purchasing shoes. 4. Buy lace-up shoes with plenty of toe room. 5. Attend for regular podiatry. 6. Keep feet away from heaters, hot water bottles, and other hot objects. 7. Check temperature of bathwater before entry. 8. Avoid walking barefoot, especially outdoors. And 9. Use moisturizing cream for dry, fissured skin. Let's now discuss macrovascular complications. The principal underlying process associated with macrovascular complications in people with diabetes is atherosclerosis. Macrovascular complications contribute significantly to increased morbidity and mortality rates in these patients. Cardiovascular disease is responsible for up to 80% of deaths in people with type 2 diabetes, as published by Hafner and colleagues in 1998. The main macrovascular complications include 1. Cardiovascular disease that encompasses both coronary artery and cerebrovascular disease. 2. Peripheral arterial disease abbreviated as PAD, e.g. intermittent claudication, ischemic foot. And 3. Erectile dysfunction, which also has neuropathic component. The main modifiable risk factors for atherosclerosis in diabetic patients are 1. Hypertension, 2. Dyslipidemia, and 3. Cigarette smoking. We will now discuss managing cardiovascular risk in diabetes. The risk of developing cardiovascular disease is increased 2 to 4 times in patients with diabetes, as published by Redberg and colleagues in 2002. Broadly speaking, a person with diabetes has an equivalent risk of suffering a myocardial infarction to a non-diabetic patient who has already suffered an infarction, as published by Hafner and colleagues in 1998. This equivalence has led to the scrapping of CVD risk prediction charts for patients with diabetes, favoring a more aggressive approach to management of CVD risk factors in people with diabetes. In 2005, the Joint British Societies recommended that preventative interventions in patients with type 2 diabetes should be afforded the same priority status as those of coronary heart disease patients (JBS) 2005. More recently, in 2009, similar recommendations were made in the NICE Clinical Guideline 87, Type 2 Diabetes, Newer Agents, partial update of CG66. We will now discuss lifestyle. Several lifestyle measures that can reduce the incidence of CV events in people with diabetes are listed below. The lifestyle targets for reducing CV events include 1. Do not smoke. 2. Maintain ideal body weight, BMI 20 to 25 kg per meter squared in adults, avoiding central obesity. 3. Keep total dietary intake of fat to equal to or below 30% of total energy intake. 4. Keep the intake of saturated fat to equal to or below 10% of total fat intake. 5. Keep dietary intake of cholesterol to below 300 mg per day. 6. Replace saturated fats by an increased intake of monounsaturated fats. 7. Increase the intake of fresh fruit and vegetables to at least 5 portions per day. 8. Regular intake of oily fish and other sources of omega-3 fatty acids, at least 2 servings of fish per week. 9. Limit alcohol intake to below 21 units per week for men or below 14 units per week for women. 10. Limit the intake of salt to below 6 grams of sodium chloride or 2.4 grams sodium per day. And 11. Regular aerobic physical activity of at least 30 minutes per day, most days of the week, should be taken, e.g. fast walking, swimming. Pause the video and carefully scrutinize this table before advancing to the next slide. Pause the video and carefully scrutinize this table before advancing to the next slide. Pause the video and carefully scrutinize this table before advancing to the next slide. We will now discuss blood pressure and hypertension. The risk of CVD increases as blood pressure increases. In the UK PDS, a mean difference of 10 mm of mercury and 5 mm of mercury in systolic and diastolic pressures between the two arms reduced the risk of 1. Heart failure by 56%, 2. Stroke by 44%, and 3. Peripheral arterial disease by 34%. The UK PDS concluded that strict blood pressure control was more important than strict glycemic control in preventing macrovascular complications in type 2 diabetes. Next we will discuss blood pressure targets for people with diabetes. Any person with diabetes who displays a persistent blood pressure above 140 systolic 90 diastolic requires both lifestyle and therapeutic intervention to reduce their CVD risk. Optimal blood pressures in this group are below 130 systolic 80 diastolic, according to the JBS2 and NICE. Reviews of major outcome trials have consistently demonstrated that the benefit from antihypertensive therapy derives from blood pressure lowering and that, in general, the various classes of drugs are as effective as each other at reducing cardiovascular morbidity and mortality per unit fall in blood pressure, according to the HOPE study of 2000. It is evident that multiple antihypertensive agents are required in the majority of patients to achieve evidence-based BP targets. Hypertension optimal treatment, abbreviated as HOT, study practitioners are encouraged to use a stepwise approach to the management of hypertension, following the ABCD algorithm. This algorithm, although not validated by any clinical trial, was designed to improve blood pressure and is recommended in JBS2 guidelines. Next we will discuss blood lipids and dyslipidemia. Diabetic dyslipidemia is an important determinant of coronary heart disease risk and is open to therapeutic intervention, according to NICE, 2009. Cardiovascular risk is determined by the concentration of LDL cholesterol and HDL cholesterol, inversely, and, to a lesser extent, by the concentration of triglycerides, as published by Smith and colleagues in 1992. Increased plasma cholesterol and particularly increased LDL cholesterol is a major coronary heart disease risk factor among people with diabetes, just as it is in the non-diabetic population. Hypertriglyceridemia and low levels of HDL cholesterol are common, particularly in type 2 patients, and significantly contribute to overall coronary heart disease risk, according to Taskanen, 2003. Important qualitative lipoprotein changes, which occur in diabetes, are also likely to increase cardiovascular risk. Pharmacological intervention with lipid-lowering drugs should be mandatory in all patients over the age of 40 years with type 2 diabetes, and in similar age groups for patients with type 1 diabetes who have established macrovascular disease, according to JBS2, 2005. Many patients with uncomplicated diabetes are at a high vascular risk and fulfill the absolute risk criteria for statin therapy for primary prevention, according to JBS2, 2005. Subgroup analysis for many of the recent major coronary heart disease secondary prevention trials with statins have shown that patients with diabetes benefit to a similar or greater extent than people who do not have diabetes, according to HPS, 2003. The collaborative atorvastatin diabetes study, abbreviated as CARDS, 2004, was the first primary prevention study to report on the benefits of statin therapy in a type 2 diabetes population. Results demonstrated benefits for patients at lower LDL cholesterol levels than those previously recognized as requiring intervention. Regarding the targets, 1. Total cholesterol should be below 4 millimoles per liter. And 2. LDL cholesterol should be below 2 millimoles per liter. Fasting triglycerides are recommended to be below 1.7 mmol, L and HDL cholesterol above 1 mmol per liter in men and 1.2 mmol per liter in women, but these are not specified targets as there is no consensus around target levels for these parameters. Regarding drug treatment, major outcome trials have consistently demonstrated that statins provide the greatest reductions in fatal and non-fatal coronary events, as well as all-cause mortality, compared to other lipid-lowering therapies. They are considered first-line agents for CVD risk reduction in people with diabetes. NICE 2009 recommends statin therapy in most patients with type 2 diabetes, commencing with simvastatin 40 mg and adjusting therapy if necessary to achieve the above targets. Significant elevations in triglycerides respond better to fibrate therapy than statin therapy, as published by Sahar and colleagues in 2007. Nicotinic acid and omega-3 fish oils may be used under specialist supervision to manage dyslipidemias that are more resistant to treatment. Pause the video and carefully scrutinize this table before advancing to the next slide. Pause the video and carefully scrutinize this table before advancing to the next slide. Pause the video and carefully scrutinize this table before advancing to the next slide. Next we will discuss antiplatelet therapy. JBS 2005 recommends aspirin 75 mg daily in people with type 2 diabetes who are 1. Equal to or above 50 years of age and selectively in younger people with any one of the following criteria. 2. Have a history of diabetes for above 10 years. 3. Have established atherosclerotic disease. 4. Are receiving treatment for hypertension. And 5. Have evidence of target organ damage in the form of retinopathy or nephropathy. NICE 2009 recommends offering aspirin to persons above 50 years of age and BP below 145 systolic 90 diastolic and to those below 50 years of age who have significant cardiac risk factors. In 2008, the POP-ADAD study, and in 2009, the ATT study, questioned the value of prescribing aspirin for primary prevention. It is important to lower blood pressure to below 145 systolic 90 diastolic before commencing aspirin to offset the risk of hemorrhagic stroke. Clopidogrel can be used if aspirin is contraindicated or in cases of proven intolerance. And now we will discuss insulin safety. Regarding insulin therapy errors, insulin is an essential life-saving therapy that is prescribed to manage patients with diabetes and, in general, its use is safe and effective. Unfortunately, errors by clinical staff in the prescribing or administration of insulin are all too common. In certain cases, these errors have been severe and have resulted in patient harm or death. Between August 2003 and August 2009, the National Patient Safety Agency received 3,881 wrong-dose incident reports involving insulin, according to NPSA 2010, and in February 2006, the BBC News reported that hospitals in Northern Ireland have said staff gave wrong dosages of insulin to patients 33 times in recent years. Insulin is one of the top 5 high-risk medications in the hospital inpatient setting, according to Doe, 2004, and medical literature has cited insulin therapy errors as a large and clinically important problem in the hospital setting, as published by Hellman, in 2004. Common causes of errors with insulin are inaccurate dosing and administration, leading to hyperglycemia or hypoglycemia. Hypoglycemia can occur suddenly if too high a dose of insulin is administered to a patient and, if left untreated, can cause confusion, clumsiness, or fainting. Severe hypoglycemia can lead to seizures, coma, and death. When prescribing or administering insulin, 4 important points must be considered. 1. the type, 2, the dose, 3, the time, and 4, the route of administration. Thank you.